A pregnant patient, 28 weeks gestation, presents with an uncomplicated DVT of her left leg. What are you going to prescribe for treatment? Pregnant, refer to OB, unfractionated heparin, low molecular weight heparin, rivaroxaban, or warfarin. Very good. So the majority of you correctly identified low molecular weight heparin, and this is just about knowing which anticoagulant drugs are safe to give in pregnancy and which are not. So brief review of anticoagulation drugs. We have vitamin K antagonists like warfarin. We have our heparins and low molecular weight heparins. And then we have our direct oral anticoagulants, our factor Xa inhibitors, and our direct thrombin inhibitors. And we have our parenteral drugs in these categories too, like fondaparinux, which is an injection Xa inhibitor, and argatroban, which we discussed in HIT, which is a parenteral thrombin inhibitor. So it's important to organize these drugs into their proper class based on mechanism of action. And that's where the coagulation cascade comes in handy again. And this is just to remind us that the Xa inhibitors work at the ever so important Xa, that's the final common pathway here, converting prothrombin to thrombin. And then the thrombin inhibitors work right here on inhibiting thrombin. And then the vitamin K antagonists work on largely 7, but also 2, 9, and 10. The take-home point from this chart on the DOACs is the reversal agents. This is relatively new. We now do have reversal agents for both of these drugs. Know that for Xa inhibitors, your reversal drug is andexanet alpha. And for thrombin inhibitors, it's idarucizumab, a monoclonal antibody. Both of these reversal agents have significant risks of overcorrecting the other way and leading to thrombosis. And as a result, you must reserve them only for serious or life-threatening bleeding. You're not going to use this for minor bleeding in a patient that's on a DOAC. Andexanet has an X in it. Factor 10 is an X. All of the Xa inhibitors have an X in them. So you'll never forget that if it's on an MCQ, and you have to remember which was the reversal agent for Xa and andexanet alpha for the Xa inhibitors. And then just a few pearls here on venous thrombosis, certain scenarios where one anticoagulant drug may be preferred over another. For your reference, we talked about argatroban and HIT. Low molecular weight heparin is going to be your preferred drug in pregnancy. And then duration of therapy. This is a very common question that comes up. And probably the most straightforward way I can explain this is that you're going to have some scenarios that are best treated with a finite three-month course of anticoagulation. That's going to be patients with first episode provoked clot with a reversible risk factor. So following orthopedic surgery, for example, right? 3 months. And then on the other end of the spectrum, you're going to have some patients that should be treated with indefinite anticoagulation. Multiple episodes, recurrent unprovoked clotting, or clotting associated with severe thrombophilia and positive family history, antiphospholipid syndrome, right? Indefinite. And then everybody else falls in the middle, where it's just a risk-benefit discussion, and according to the ACCP guidelines, you consider indefinite anticoagulation, let's say, for example, for a first episode of unprovoked VTE, but it just falls in that gray zone middle where you discuss with your patient. And there's certainly more nuances to that than what I've gone over, but that's just kind of a basic framework. IVC filters, if you're going to put one in, make sure you have an indication for it. And those indications are only a few. When you have contraindication anticoagulation, failure of anticoagulation, or a patient with active clot and severe cardiopulmonary compromise where you're looking at them and you say if they shower one more clot from their leg, they're not going to survive it, then you put in a retrievable IVC filter.